Welcome back to another episode of the Medical Alley Association podcast series, Leadership Through a Crisis. Our guest today is James Hereford, President and CEO of Fairview Health Services. James, thanks for sitting down with us. Why don't you start by telling our listeners a little bit about yourself and your company?
Hi, my name is James Hereford. I'm the President and CEO of Fairview Health Services. We're a $6 billion revenue healthcare delivery system, health plan, and various other elements of a complete continuum of care, headquartered here in Minneapolis, serving Minnesota and a little bit of Western Wisconsin.
And so I imagine in your particular circumstances, the situation with COVID-19 got really real, really fast. Can you talk to me a little bit about when the situation and the gravity really started to hit home?
Well, I think once it became a domestic issue and we started to see some of the impacts, especially in Seattle, that they were facing, that was where we felt like, well, it's inevitable that this virus is going to spread. Wasn't long after that, we stood up our own incident command structure to start to be able to be in a position to respond effectively. And it wasn't long after that that we saw our first cases. And one of the most significant cases was a 38-year-old triathlete who was admitted into our academic hospital with severe consequences. He's since recovered, thankfully, and is now training for his next triathlon. But it was at that point that we really started to think about what we were going to have to do to respond. And the challenge at that point also was there were so many things we just didn't know about how the disease spread, who would be targeted, who was the most susceptible. So it was also this ongoing process of learning and discovery. Both from our own experience, but then the experience of people, not just across the country, but across the world.
And so when that hit you, how did your role have to change and how did Fairview have to change?
Well, I think initially I became a little bit more operationally involved as we were setting up the incident command structure. I'm, fortunate. We have terrific operational leaders, and Laura Reed, Mark Welton, Greg Beelman. There are just a number of people who really took the incident command structure, which is basically built for responding to crises, and used that and leveraged it as a mechanism for how do we think about what our organization needs to do. There were still significant policy issues that came up that I had to be involved in. But frankly, a lot of my time was spent on the coordination between healthcare systems in the state, how we were thinking about the broader response, because this was clearly not something that was, only one organization's responsibility or was only going to impact a single organization. It was really destined to impact all of us.
What were some of the biggest issues you had to tackle personally and from Fairview's point of view?
Well, I think initially it was just the shortages around PPE and some things that on a normal basis you don't worry about because the supply lines are clear. You very rarely run out of surgical masks or surgical gowns. N95 masks were never a question about whether you'd have enough, and suddenly it became an acute shortage. And especially as a lot of the supply lines were disrupted, because much of that is sourced from China. But then it was also disrupted because a lot of those supplies were going to the hardest hit areas in the US. So New York and Seattle were getting a lot of those initial supplies. So that was very different, and we had to respond to that. But I think the thing that was maybe the most impactful was the way that we worked. And part of the incident command structure changed the way we worked. And so we suddenly had to now morph and think about creating a virtual command structure and take the kind of infection control measures for our own management activities that we were thinking about so diligently in our care delivery activities.
And so the incident command structure, was that something you had planned ahead for, or was that something created as a result of COVID-19?
No, it's in almost every healthcare organization, especially of our size, has and drills on an incident command structure because things always happen. Um, you hope you never have to use it, but inevitably you do. I know when I was at Stanford, we had a plane crash at San Francisco Airport that we had our incident command structure that we immediately stood up. The difference is that it's usually for mass casualty events, a major uh, earthquake or something like that. The duration of this was so much different. And so that's where we had to adapt our thinking around how does an incident command structure work when it's, it may be months, it may be much longer that we have to run this because we simply don't know.
And so going back to the conversation about PPE, it seems collaboration was critical to solving some of those issues. Did collaboration solve those issues, or is it still sort of a work in progress that is being made better through collaboration?
Well, it's a constant, I don't know, battle may be too strong, but it's a constant part of the work is making sure that we've got effective supply lines to make sure our supply chain has integrity, that we have the equipment we need. A lot of coordination with the state. They have their own incident command structure that they stood up. And thankfully there was a structure that was really pretty well in place. But also, a fair amount of credit goes to Medical Alley. We leveraged them significantly because part of the challenge was trying to decipher between the credibility of the offers, because nothing brings out various sorts of opportunists like a crisis. And our challenge was, we're not built to be able to understand, to look at factories in China, to understand the integrity of the supply line. And Medical Alley was an invaluable resource to us to be able to work to understand, what was on the other side of that offer. Were these supplies that met our quality standards that we could depend on? And so we leveraged Medical Alley pretty significantly, along with the state and their own incident command structure.
You mentioned having to potentially move the incident command center to a virtual operation. It seems as though healthcare is also moving that direction. Has Fairview had to pivot towards telehealth? Has it always operated that way, or was COVID-19 a catalyst for greater use of telehealth?
Well, I think it's fair to say it was a catalyst. We probably made more progress in virtual care in a couple of months than we had in the prior couple of years. We've always been a somewhat of an early entrant into virtual care. We were a founding member, an investor in Hypnosis. One of our physicians was one of the people who was involved in that founding. But the work to integrate it into clinical practice, to be able to socialize it, to make it work at a scale that wasn't the exception, but was more the rule. All of that came in very intense work, again, through our incident command structure, but on the ambulatory side, to really start to integrate virtual care in a way that it became much more dominant. Now, one of the things that changed was payer reimbursement, because the challenge with virtual care outside of specific environments like a Kaiser where you have prepaid healthcare is in a fee-for-service environment, virtual care always pays less. And so you are asking a physician to essentially take less money to do a virtual visit as opposed to a physical visit. And inevitably, when the economics run contrary, you tend to get the behavior that maximizes the economic return. So it was much more likely that people would use a physical visit as a mechanism, even if that wasn't required. And it was normative. It was what people knew. It's how they'd been practicing and how they'd been experiencing care for years and years. I think the COVID crisis forced us both to be adaptive from here's how we think about delivering care, but also from the experience that patients were having in terms of being able to get that virtual care. But also then the gradient largely went away for COVID-related issues. And so reimbursement was much more, there was much more parity between the types of reimbursement. In many ways, that makes complete sense. It shouldn't matter. The only thing that really matters is what's clinically appropriate. And if it's as equally clinically appropriate to put somebody in an exam room as it is to treat them in their living room virtually, then why wouldn't we take the path that is the most convenient and the most effective for the patient, which is in many cases virtual.
Do you see that continuing in a post-COVID environment?
Well, I certainly hope so. I mean, I don't have control over where payers set their reimbursements, except for our own payer. Certainly, we plan on maintaining that level of parity. I know in several conversations with the Center for Medicare and Medicaid that they are certainly trying to maintain that parity. I think many of the payers that we work with are also doing that. So, the proof is always at the end of the day whether that happens, but I think the intention has been pretty well articulated because we've demonstrated the effectiveness of this in this kind of environment.
I think another issue many in your position have been dealing with is the continuum of care for non-COVID patients. How have you been addressing that?
Well, that's been, again, I've been gratified to see some of the innovation that's happened. Some of it has come out of the university with College of Engineering and others in terms of how do you, because the challenge is always because of the number of people who may have COVID but be asymptomatic. You always had to treat everybody like they had COVID. And especially when we had less testing available. So there were all kinds of innovative ways, including, essentially a kind of a phone booth that allowed people to treat patients, in a kind of a drive-through, if you will, a walk-up, but not have to don and doff PPE all the time because they could be in their isolated environment, but still interact with the patient. So there was a number of very adaptive, innovative things that occurred to allow us to continue to treat patients. Many of our volumes were much less because people were concerned about the environment, but we've now seen that recover reasonably well too, of being able to access care on an ambulatory side as well as an inpatient side for non-COVID related things. And we've come so far in being able to manage in a routine way this infection control process. And part of that, again, I think was a credit to the innovation of our team. We stood up a COVID specialty hospital where most of our COVID cases were treated. And it allowed us to cohort the COVID patients, develop a level of expertise and capability there, but keep more of our facilities open for other kinds of care.
I think another thing that COVID-19 brought to the forefront is addressing health inequities. Can you talk to me a little bit about how Fairview has been tackling those kinds of issues?
Well, I think you're right in pointing out what it did was basically shine a very bright light on existing health inequities. And I think we've seen that play out because of COVID, and there is increasing data to support that view and the actual impact it's having. If you're Hispanic, if you're African American, et cetera, you're much more likely to get COVID, to have significant implications of it, along with seniors. And often it's seniors who have other disadvantages, economic or otherwise. And that does connect back to what can be referred to as social determinants. I like to think about them as social risks. Determinants makes it sound like you don't have there's nothing you can do about it, it's determined, as opposed to these are risk factors that we should be able to think about how do we intervene. Certainly the events that followed the murder of George Floyd and all the social unrest that occurred certainly got our attention about we need to do more to uphold our end of that social contract. And we've always been very active through our foundation, our community relations function, working on, whether it's access to food disparities, access to housing disparities, et cetera. But really, we felt, and I felt personally, that we had to really redouble and organize our efforts in a much more effective way. So, and it's our patients, but it's also our own people, right? We need to make sure that our people are free to come to a work environment that's free of bias, that allows them to be their best selves, to be able to grow and develop effectively. And so we've have a group of our leaders who have taken the task of putting together this commission, what they've self-titled the Hope Commission, to address all of those and to really look systemically across all of our care environments and in our communities to say, how do we address this, and how do we uphold, as a major part of the social contract, how do we uphold our end of that as a healthcare organization?
So, those are all very serious and important issues. And putting the focus back on you, was James Hereford made for this moment? How do you tackle all of these issues and not buckle under the stress and the pressure?
Well, I don't know that I don't know that anybody should have the hubris to say that it's wow, this was a natural thing. Of course, it was easy. None of this is easy for any leader. These are challenges, and often challenges that we've never faced in a similar circumstance before. I think I was fortunate in that I've been in prior roles in many very good organizations, whether it was in Seattle or California, in Stanford or Sutter, or now here, and gained tremendous experience, had invaluable relationships with leaders who taught me a great deal. And there is probably some aspect of all my degrees are in mathematics or statistics. I love problems, and I love the analysis of a problem that leads to a solution. And so there is a part of me that did enjoy the complexity and the problem solving that occurred. I think, again, it comes down to so much of this isn't done by me, it's done by other people. And my job is to support them, make sure they're in the right position, they have the right resources, they feel supported. That felt relatively natural to do, because I have such great, I have great colleagues, and it's easy to, try to support them and get behind them.
Well, it sounds like you're a great leader, and you're a good leader not only with Fairview, but you're also a leader on the Medical Alley Association Board of Directors. And in that role, you've gotten to really see a deep dive into what this industry has been doing since COVID-19 hit. Can you tell me a little bit about what you observed?
Well, let me say first, at the Minnesota level, everybody talks about, what a collaborative environment is, but until you're here and you're experiencing it, you can't fully understand it. The fact that even in our very competitive healthcare environment, we get together as CEOs of the largest healthcare organizations to say, how do we collaborate? How do we think about this collectively? But the point about Medical Alley is a great, I think, example of a unique Minnesota institution that continues to strive to be more than what it originally was, right? Obviously, it started, its genesis was around the foundation of this wonderful medical device home that we have for so many terrific companies. But what I've seen Medical Alley become in my short experience with them really goes well beyond that they're thinking, broadly about healthcare. They're thinking inclusively about healthcare, bringing payers and care delivery systems and device companies and consumer organizations and startups together in a way that we can find our commonalities, that we can have that kind of environment to collaborate in. And as I referenced earlier, there's a set of capabilities that Medical Alley has that has been incredibly important in our ability to respond to this crisis. So that's been very enjoyable. It's an organization that I'm not sure you could have anywhere but Minnesota in the way that it performs.
Thank you again for listening to the Medical Alley Association podcast series, Leadership Through a Crisis. To make sure you don't miss a single episode, be sure to follow us on all of our social media platforms, subscribe to our newsletter, and visit us at medicalalley.org.